Good afternoon. We are here at Barcelona for the 55th annual scientific meet. The EASD also is renowned for its good scientific design, good education, and good research. And that makes it the largest global congress body in diabetes. We have here with us one of the key pillars of this meeting, Professor Mikael Rydén. He is the Honorary Secretary and the Scientific Program Chairperson, and his focus of research for the last many years has been on intracellular signaling and secretory function of human adipose tissue, especially in conditions of weight gain and weight loss. You must have heard yesterday on the DAPA heart failure study. There has been a paradigm shift in our therapy, in the guidelines, where the SGLT2 inhibitors are really making waves, not only in the field of endocrinology, but also overflowing into the cardiology world. And from the DAPA heart failure study, we have seen that it has made a great change in the health status, not only in diabetic patients, but in the non-diabetic fraternity as well. So, Professor Rydén, do you foresee a therapeutic change where the cardiologists will be using this molecule much, much more than the endocrinologists?
So I really believe that this is a paradigm shift. I just came from the presentation, and the paper is now out in New England Journal of Medicine just as we speak. This is a major transformation of the field. So this implies that for the first time, an anti-diabetic drug can be and should be used even in subjects without diabetes. I can see from the European perspective, our experience is that the cardiologists have looked upon SGLT2 inhibitors as something that would be prescribed by the GPs. Now, this trial and upcoming trials that are on the way will obviously shift that completely, and this will now be a drug class that is appropriate for diabetologists, for GPs, for cardiologists, for nephrologists, and many, many different specialists will need to know much more about these drugs, their positive effects, but also their side effects and the possible caveats you need to take into account when you prescribe these. So I definitely agree that this changes the entire way we look upon this drug class.
Now, coming to your field, sir, you have spent a lifetime in the realm of adipose tissue and obesity. And seeing it from the Indian point of view, we are thin, fat Indians. That means we have more fat, but we look thin from the outside. And for the same BMI, our fat composition is much more than the Westerners, like Europeans and Americans. Where would your work help us in defining this? Is it genetic? Is it environmental? How can you bring your work from the bench to the bedside?
So one of the problems, I think, is that I, of course, work in Sweden, and the majority of the people are white Caucasians, and I think that's a drawback for us, because obviously type 2 incidence and obesity, or type 2 diabetes, even with obesity that is not defined as obesity by BMI criteria, but it's internal obesity in the sense that you have a high fat percentage, like for instance in India, but also in Japan. I mean, this is a major global health problem. We have the same situation in China, Korea. I'm extremely interested in understanding that, but I don't have the patients in Stockholm where I sit. But I'm really interested in trying to understand and tease out what happens, because I think that the white Caucasians, they are the exception. I mean, there's something strange with them. I think that the way humans react to an obesogenic or diabetogenic environment That's what we see in the rest of the world. For some reason, we Caucasians have been protected, possibly because we have lived in a colder area where it was more important to be able to feed during the winter, to withstand the cold temperatures. There could be many other reasons, but I agree that this is the next challenge in the next few decades to understand. And we talk about the mechanism. We also talk about precision medicine, trying to tease out who benefits the most from different drugs. It is imperative that when we prescribe these drugs that we also take into consideration ethnicity, because we know from the hypertension field that there are clear differences in how you react to different drug classes depending on ethnicity. I believe that we will see similar things in the diabetes field, and I hope that in 10 years we will know much more about how we should treat subjects, not only on age, gender, ethnicity, but also on all the other parameters that make us respond to different drugs in different ways.
In continuation to what you have said, those who live in the colder countries like the Caucasians, do they have an excess amount of brown fat and that is raising their BMI?
So this is an interesting question, and it has been actually checked in smaller studies, admittedly, but I think we can safely say that brown adipose tissue or brown adipose tissue activation cannot explain these ethnic differences. Brown adipose tissue activation in adult humans probably explains a very, very minor fraction of energy expenditure. And in general, we have to remember that even though we live in cold countries, our living conditions are very, very warm. We put on a lot of clothes, we have very warm apartments and so on. So in effect, we might not be as cold exposed as one would think just by looking at the outside temperatures. The short answer is that brown adipose tissue cannot explain this.
And the last question, sir, what message would you give from this EASD to the delegates who attended, to those who are going to hear us online, and to my people in India? What would you say to them?
I think that for all subjects with type 2 diabetes in the world, you are living in the right decade. There is hope. There are now good treatments, validated treatments that will keep you alive for a longer time with higher quality of life. So I think that from this it can only improve further, I think.
So thank you so much. I'm really privileged to hear Professor Rydén.